This recorded lecture will be going over Chapter 18, Drug Therapy for Diabetes, in the Introduction to Clinical Pharmacology textbook. Diabetes mellitus is a common chronic endocrine condition in which the lack of insulin or poor function of insulin impairs glucose metabolism. This leads to problems in fat metabolism and protein metabolism that can affect the functioning of every body system. Glucose is a simple sugar, important for energy production in cells and organs. It is also a part of many carbohydrates. Insulin is a hormone produced by the area of the pancreas known as the islets of Langerhans and works to regulate the amount of glucose in the blood. Like other hormones, insulin is a key that binds to its cellular receptors, which then acts as a lock. When the insulin binds to its receptors, doors on cell membranes open, allowing the glucose to enter the cells. This lowers the blood glucose level. Glucose in the cells is metabolized to generate the cellular energy needed to maintain maximum cellular and organ function. When blood glucose levels are lower than normal, cells and organs cannot metabolize it to provide energy, and cellular function can be greatly reduced. However, too much blood glucose leads to severe complications over time, including cardiovascular disease, peripheral nerve damage, kidney failure, and damage to the blood vessels of the retina that can cause blindness. Good glucose control, sometimes called glycemic control, will require balancing blood glucose so that levels are consistently in a normal range. Insulin will prevent hyperglycemia by allowing the body cells to take up, use, and store carbohydrates, fat, and proteins. It is known as the hormone of plenty because its release is triggered by a high blood glucose level. The actions of glucagon are the opposite of insulin. It prevents low blood glucose levels by triggering the release of glucose from storage sites in the liver and skeletal muscle. Glucagon is called the hormone of starvation because its release will be triggered by a lower than normal blood glucose level. You can also see this on page 328 in the orange memory jogger box. Blood glucose levels after a meal are controlled by the emptying rate of the stomach and delivery of nutrients to the small intestine, where they are then absorbed into circulation. Incretin hormones, secreted in response to the presence of food in the stomach, will work with insulin to prevent blood glucose levels from becoming too high after a meal. The brain and other parts of the nervous system will require a continuous supply of glucose from the blood because they cannot store it. In the liver and muscles, glucose can be stored as glycogen. Fats are stored as triglycerides in fat cells. Insulin helps keep blood glucose levels from becoming too high, helps maintain blood lipid levels in the normal range, and prevents muscle protein breakdown. Recall that in diabetes mellitus, the lack of insulin or poor functioning of insulin will impair glucose metabolism. When there is not enough insulin, or when insulin does not bind well to its receptor, glucose will not enter the cells and instead circulate unused and at high levels within the blood. For this reason, the main feature of diabetes is chronic hyperglycemia. About 29 million people living in the United States and about 2 million people in Canada are living with diabetes. Another 90 million have pre-diabetes. This is an abnormal glucose metabolism that carries a high risk for developing into actual diabetes. Diabetes that is not well controlled can reduce the function of all organs and tissues. The most serious complications of uncontrolled or poorly controlled diabetes include hypertension, high blood lipid levels, early onset cardiovascular disease, kidney failure, strokes, and blindness. The classic symptoms of diabetes are polydipsia, polyuria, and polyphagia. If insulin is not produced by the pancreas, or there is a problem with the insulin binding to its receptor, the cells cannot use glucose for energy. To make up for this problem, the body will break down fat and protein in an attempt to provide energy and increase the production of glucose from other sources. When this stored fat is used for energy, keto acids are formed and will collect in the blood. This results in a dangerous and potentially fatal condition known as ketoacidosis. In addition to the diabetes that can occur with pregnancy, there are two main types of diabetes mellitus. Type 1 diabetes mellitus is an autoimmune disorder in which the beta cells of the pancreas that store and release insulin are destroyed. This can occur as a result of a genetic predisposition or as a response to infection by certain viruses, like rotavirus or coccidiovirus. Diabetes mellitus type 1 is often diagnosed in childhood, sometimes even before the child is 1 year old. With diabetes type 1, the pancreas produces no insulin. Therefore, the patient must take insulin daily for the rest of their life unless they receive a pancreas transplant. Diabetes type 2 is a disorder in which the person continues to make some insulin, but it doesn't bind well to its receptors. There is also a reduced response of the body to insulin, known as insulin resistance. Eventually, the pancreas will make less and less insulin. Insulin resistance develops due to obesity and decreased physical activity in people who may already be genetically predisposed. Usually, diabetes mellitus type 2 will develop in adulthood. Although, with childhood obesity on the rise, some children are being diagnosed with this form of diabetes. About 90% of people with diabetes have diabetes type 2. Although far fewer people have diabetes type 1, it is typically diagnosed more quickly because the initial symptoms will be sudden and severe. It is important to remember that whether a person has diabetes type 1 or type 2, the long-term complications will be the same and will often shorten the lifespan. Although insulin may be necessary for some people with diabetes type 2, diet, weight reduction, and non-insulin anti-diabetic drugs are typically effective in maintaining good glycemic control. Non-insulin anti-diabetic drugs are oral and injectable drugs that use a variety of mechanisms other than binding to insulin receptors to help lower the blood glucose levels. The goal of drug therapy for diabetes type 2 is to help keep blood glucose levels within the normal target range in order to not make the person hypoglycemic. Hypoglycemia is a serious adverse effect on some of these drugs, but it is not the desired effect. Non-insulin anti-diabetic drugs will be prescribed with diet when diet and exercise alone are not enough to maintain the blood glucose at target range. These drugs will not be a substitute for diet and exercise, but should be used in addition to them. If the first drug does not adequately control blood glucose levels, a second non-insulin anti-diabetic drug that works differently may be added to the first or used alone. Insulin therapy is used only when blood glucose target ranges cannot be met with the use of 2 or 3 different types of non-insulin anti-diabetic agents. The non-insulin anti-diabetic drugs can be divided into 8 categories: insulin stimulators, biguanides, insulin sensitizers, alpha-glucosidase inhibitors, incretin mimetics, DPP4 inhibitors, amylin analogs, and sodium glucose cotransport inhibitors. Insulin stimulators are oral non-insulin anti-diabetic drugs that lower blood glucose levels by stimulating the release of insulin stored in the beta cells of the pancreas. The patient should have some functioning beta cells for these drugs to work. They will improve the movement of glucose into cells by increasing the number of insulin receptors on the cells or enhancing the actions of activated insulin receptors. They are used only for diabetes type 2 and are often used with other non-insulin anti-diabetic drugs for best blood glucose control. These can also be combined with insulin. Sulfonylureas and meglitinides are the 2 classes of drugs within this category. Some common side effects of sulfonylureas include heartburn, nausea, vomiting, abdominal pain, and diarrhea caused by increased gastric acid secretion. They also increase sun sensitivity, which increases the risk of severe sunburns. Common side effects of meglitinides include upper respiratory infections, back, joint pain, and dizziness. A serious problem with insulin stimulators is that over long periods, they eventually cause the beta cells of the pancreas to stop producing insulin. This is a condition known as secondary beta cell failure. All of these drugs can affect the liver and do increase liver enzyme levels. Some drugs or drug groups will enhance the hypoglycemic effect of insulin stimulators. This would include aspirin and other NSAIDs, angiotensin ARBs, ACE inhibitors, beta blockers, warfarin, azole antifungal drugs, and many other antibiotics. Other common drugs can increase the risk of hyperglycemia. These would include corticosteroids, furosemide, isoniazid, pseudoephedrine, antiretroviral protease inhibitors, and thiazide diuretics. Always consult a drug reference book or pharmacist for more information. On page 331, see the purple top tip for safety. Sulfonylureas can decrease the effectiveness of certain contraceptive drugs. Women of childbearing years who are taking this anti-diabetic drug will need an alternative contraceptive method to avoid pregnancy. To avoid making hypoglycemia worse, assess patients for signs and symptoms of hypoglycemia before giving an insulin stimulator. Signs of hypoglycemia include tremors, sweating, confusion, rapid heart rate, hunger, nervousness, and inability to concentrate. If any indications are present, check the patient's blood glucose level. If the patient is NPO or is not eating a meal for some other reason, do not give the drug. Teach your patient and family the following. Take these drugs with or just before meals to prevent hypoglycemia. If you skip a meal, also skip your drug dose. For signs and symptoms of hypoglycemia, patients should consume some sugar, like a glucose tablet or gel, half a cup of juice or regular soda, or 1 tablespoon of honey or sugar. Consult your healthcare provider or pharmacist before taking any additional supplements or over-the-counter drugs. Common but expected side effects of these drugs include nausea, headache, and weight gain. Biguanides are oral, non-insulin, anti-diabetic drugs that lower blood glucose levels by reducing the amount of glucose the liver releases and by reducing how much and how quickly the intestines absorb the glucose from food. Unlike the insulin stimulators, biguanides do not force the pancreas to release insulin from the beta cells. The only drug in this class is metformin. The most common side effects of metformin are related to the GI system. This would include nausea, diarrhea, flatulence, and weight loss. These side effects will typically decrease over time. Metformin use is associated with a risk of lactic acidosis. This is an unusually high concentration of lactate in the body. Signs of lactic acidosis include nausea, vomiting, rapid and deep breathing, and weakness. When used without other anti-diabetic drugs, metformin alone will not cause hypoglycemia. Metformin interacts with radioactive dye or contrast medium that can be used for some diagnostic tests. This could lead to kidney failure. For this reason, metformin should be stopped at least 24 hours before any radioactive dye is used, and then not started again until 48 hours after the test has been completed. Assess the patient's kidney function. Metformin should not be given to patients who have kidney disease because it can cause kidney failure. Metformin is safe in pregnancy for the treatment of gestational diabetes. Teach your patient and family the following. Avoid drinking alcohol while taking metformin, because this could increase the chance of developing lactic acidosis. The most common side effects from metformin are mostly forms of GI upset. Metformin should be stopped at least 24 hours before any test that uses radioactive dye, and then not started again until 48 hours after that test has been completed. Long-term use of metformin has been associated with increased homocysteine levels. This is a risk factor for cardiovascular disease and a vitamin B12 deficiency. Insulin sensitizers. These are also known as thiazolidinones. And you can see this on page 333 within table 18.3. So make note that insulin sensitizers are the same as thiazolidinediones. Insulin sensitizers are oral, non-insulin anti-diabetic drugs that lower blood glucose levels by making insulin receptors more sensitive to the insulin. This increases the cellular uptake and use of glucose. The drugs in this class are considered the thiazolidinones, also known as glitazones. These are used only for type 2 diabetes and will often be used together with other non-insulin anti-diabetic drugs for the best glycemic control. These can also be used with insulin. The US FDA has issued a black box warning indicating that these drugs are not to be used by patients with symptomatic heart failure or other types of cardiovascular disease. Hypoglycemia is a potential side effect of rosiglitazone and all agents used to treat diabetes. Headache, sneezing, and sore throat could also occur. TZDs have been associated with severe cardiovascular side effects and should be used with care. Assess your patient for any signs of allergic reaction, any signs of heart failure, and for any signs of hypoglycemia. Teach your patient and family the following. Take the drug as prescribed. If you miss a dose, take it again as soon as possible. If you miss a dose and it is almost time for your next one, skip the dose. Immediately report any itching, hives, or swelling of the face or hands to your healthcare provider. Report any changes in vision. Report swelling of the feet or ankles, or any weight gain. Avoid alcohol while taking this drug because alcohol can affect blood glucose levels, causing hypoglycemia or hyperglycemia, depending on the amount of alcohol ingested. When signs and symptoms of hypoglycemia are present, eat or drink something that contains real sugar. When signs and symptoms of hyperglycemia are present, notify your healthcare provider. And check your blood sugar frequently, especially during times of stress or illness. An alpha-glucosidase inhibitor is an oral, non-insulin anti-diabetic drug that lowers blood glucose levels by preventing enzymes in the intestinal tract from breaking down starches and more complex sugars into glucose. This action will slow glucose absorption. These drugs are primarily prescribed for patients who have a high blood glucose level after meals. These drugs were first approved to help manage diabetes type 2, but can also be used for diabetes type 1 because they work in the GI tract independently from insulin. Used alone, they will not cause hypoglycemia. The alpha-glucosidase inhibitors will prevent the breakdown of complex carbohydrates into glucose. The carbohydrates remain in the intestine, causing the passing of gas, bloating, and diarrhea. These signs and symptoms go away as the body adjusts to the drug and dose. Alpha-glucosidase inhibitors can cause the worsening of conditions associated with the inflammation of the bowel, including colitis, Crohn's disease, and intestinal obstruction. They can also cause liver impairment, and liver enzymes should be monitored. Monitor for signs and symptoms associated with hypoglycemia whenever this drug is combined with insulin or another anti-diabetic drug. Monitor your patient for any GI discomfort or diarrhea and report these findings to the healthcare provider. Teach your patient and family the following. These drugs will work best when used in conjunction with proper diet and exercise. These drugs are competitive inhibitors of the digestive enzymes, and they must be taken at the start of meals to get the most benefit. The drug effect on blood glucose levels after meals will depend on the amount of complex carbs in the meal. Avoid alcohol, and report any signs of allergic reaction to the healthcare provider immediately. Incretin mimetics are injectable drugs that act like natural gut hormones that are secreted in response to food in the stomach. Just like gut hormones, these drugs will work with insulin to prevent blood glucose levels from becoming too high after meals. They do this by increasing insulin secretion, decreasing glucagon secretion, and slowing the rate of gastric emptying. The injected drugs will work with naturally secreted insulin, and they are only approved for patients with type 2 diabetes that has not been controlled with oral drugs. They can be given by the sub-Q route, and some are long-acting drugs, require only a weekly dose. Common side effects of the incretin mimetics would include nausea, vomiting, diarrhea, and upper respiratory tract symptoms. Many patients will lose weight when taking this drug. There are several long-term adverse effects. Pancreatitis can occur in obese patients with diabetes type 2, and there is an increased risk of thyroid cancer. Many herbal products and drugs can interact with the incretin mimetics. Incretin mimetics will slow the absorption of other drugs, including antibiotics and contraceptives. Monitor your patient's blood glucose level, especially after beginning the drug. Ensure that the patient and family members understand and can demonstrate how to cleanse the skin, inject the drug, rotate injection sites, and properly dispose of needles and syringes. Teach your patient and family the following. Report any signs and symptoms of allergic reaction to your healthcare provider. Avoid alcohol intake because it will increase the risk of pancreatic inflammation. Monitor your blood glucose level regularly. Seek immediate help for severe abdominal pain and nausea, which could indicate pancreatitis. If a dose is accidentally missed, do not double up injections, but instead take the missed dose as soon as possible. Give the sub-Q injection in the thigh, upper arm, or abdomen, and be sure to rotate injection sites regularly. Give the drug 60 minutes before meals, not after the meal. Refrigerate unused injectable pens until they are used or expired. An amylin analog is an injectable non-insulin anti-diabetic drug similar to natural amylin. This is a hormone produced by pancreatic beta cells that works with and is co-secreted with insulin in response to blood glucose elevation. The only drug in this class is pramlintide. This prevents hyperglycemia by delaying gastric emptying and making the patient feel full so that they eat less. This is used for patients with type 1 or type 2 diabetes. Expected side effects include nausea, vomiting, headache, abdominal pain, weight loss, and fatigue. Pramlintide can cause severe hypoglycemia, especially when used with insulin to treat diabetes. This drug can also cause dizziness. Some drugs can affect how pramlintide works, including aspirin, atropine, disopyramide, fluoxetine, pentoxifylline, certain blood pressure and cholesterol drugs, and MAOIs. Check blood glucose levels after meals to assess for the effectiveness of the drug and screen for hypoglycemia. Teach your patient and family the following. This drug should be injected into the thigh or stomach, and injection sites should be rotated regularly. Opened vials and injectable pens should be kept refrigerated. Allow the drug to warm to room temperature before you inject it, and give this injectable drug just before your meal. Never mix pramlintide with insulin in the same syringe. Dispose of all used syringes and needles into a regulation sharps container. If you miss a dose and cannot take it within a reasonable time, skip the dose. Do not double up on doses. Do not drink alcohol when taking pramlintide. Check your blood glucose level regularly, and do not take it if your blood sugar is too low. This drug can cause dizziness, so do not drive or operate machinery until you know how it will affect you. DPP-4 inhibitors are a category of non-insulin anti-diabetic drugs that help prevent hyperglycemia by reducing the amount of the enzyme DPP-4, which inactivates the gut hormones, glucagon-like peptide, and gastric inhibitory polypeptide. This action allows the naturally produced incretins to work with insulin to control blood glucose levels. These drugs are approved only for patients with diabetes type 2. Nasopharyngitis, with cold-like symptoms of sneezing, runny nose, cough, and swelling of the nasal passages can occur. Diarrhea has also been reported. Hypoglycemia can occur when DPP-4 inhibitors are given in combination with insulin or a sulfonylurea. Reports of acute or fatal pancreatitis have occurred with these drugs. An increased risk of heart failure has been reported among patients receiving saxagliptin and alogiptin. Severe arthralgia has been reported in patients taking DPP-4 inhibitors. Monitor your patient for signs and symptoms of heart failure. Teach your patient and family the following. Take the drug as ordered. If a dose is accidentally missed and can't be taken within a reasonable time, do not double up on the dose. Just take your next dose as scheduled. Check your blood glucose level regularly. If taking saxagliptin or allogliptin, check your weight daily. Report any signs and symptoms of an allergic reaction or angioedema associated with the drug. Report any signs of acute pancreatitis. Inform your healthcare provider if you become pregnant, because it is not known whether these drugs are safe for use in pregnancy or breastfeeding. And always tell your healthcare provider all of the drugs that you're taking, including any over-the-counter or herbal drugs. Sodium glucose cotransport inhibitors are a new category of non-insulin anti-diabetic drugs that lower blood glucose levels by preventing the kidney from reabsorbing glucose that was filtered from the blood into the urine. The glucose will remain in the urine and is excreted rather than being moved back into the blood. These drugs are approved only for patients with type 2 diabetes. An increased need to urinate has been reported by patients taking sodium glucose cotransport inhibitors. Weight loss, initially through the loss of fluid, followed by a loss of fat mass, can also occur. Vaginal yeast infections and urinary tract infections are the most commonly reported adverse effects, with the greatest risk occurring among female patients and uncircumcised men. Kidney failure, hyperkalemia, ketoacidosis, increased risk of bladder cancer, and hypotension are other potential serious adverse effects. When these drugs are given with diuretics, the frequency of urination increases and dehydration can result. Check the patient's weight at the start of therapy and then again at regular intervals thereafter, because these drugs can cause weight loss. Monitor the patient for symptoms of UTI. Monitor female patients for symptoms of vaginal infection. Monitor the patient's serum potassium level for symptoms of hyperkalemia. Teach your patient and family the following. Notify your healthcare provider if you have any allergic reaction to the drug. Check your blood glucose level at regular intervals. Weigh yourself at least once per week and report any undue or unexpected weight loss. Report signs of a UTI or vaginal infection to your healthcare provider. Make sure you are drinking enough fluids throughout the day to prevent dehydration. You will see the presence of glucose in your urine if you test your urine with a glucose strip. This is expected and normal. When blood sugar levels become elevated, insulin is released from the beta cells. This helps restore normal glucose levels by moving insulin into the cells and allowing insulin to bind to the insulin receptor on the cell membrane. A fasting glucose level of 70 to 90 milligrams per deciliter is considered normal. In addition to its role in glucose control, insulin is important in fat metabolism. Adequate amounts of insulin inhibit the release of fatty acids into the blood, preventing high blood lipid levels. Insulin is an anabolic hormone, one that converts simple substances into more complex compounds. It helps maintain stores of fatty acids, glycogen, and protein. It is considered a high alert drug. On page 340, see the purple top tip for safety. High alert drug. Insulin is a high alert drug that can cause great harm when it is given at too high or too low a dose. If it is not given to a patient for whom it was prescribed, or if it's given to someone who doesn't have diabetes. If insulin is given at too high a dose or is given to a patient without diabetes, the patient could become severely hypoglycemic with a risk of death. If insulin is given at too low a dose, the patient's blood glucose level will be poorly controlled, increasing the risk of severe hyperglycemia, ketoacidosis, and death. For glucose control in diabetes type 1, multi-dose insulin injections, about 3 to 4 injections per day, known as intensive insulin therapy or continuous subcutaneous insulin infusion by an insulin pump, will be recommended. Insulin is destroyed by stomach acids and intestinal enzymes, so it must be given by the parenteral route. Various other injection sites have been developed to simplify insulin injection. Some of these devices are designed to look like a pen. The patient will set the dial to the insulin dosage needed and then touch the tip of the device to the skin, where the insulin will be automatically injected. These products will not need to be refrigerated, and they can be easily carried by the patient. Each diabetic patient who needs insulin will be prescribed an insulin regimen. This is a schedule of insulin doses aimed at preventing hyperglycemia. The dose of insulin and how often it should be given will vary among patients. Typically, patients take a long-acting insulin in the morning and then a short-acting insulin to cover meals and snacks. Whenever short-acting insulin is given before a meal, the patient must eat the meal within 15 minutes of receiving the injection to prevent hypoglycemia. The insulin regimen is determined by the patient's blood glucose levels, age, activity level, and their eating habits. Patients must be taught how to perform home glucose monitoring and maintain a written or electronic record of their test results. This information, along with the hemoglobin A1C, will be used by the healthcare provider to adjust the insulin regimen. Many types of insulin are available. This includes rapid, short-acting, intermediate-acting, and long-acting formulas. These types will differ mostly in their duration of action. Almost all insulin used today is synthetic. All types of insulin are regarded as high-alert drugs due to the severity of the effects that could occur if insulin was given in the wrong dose or to the wrong patient. Expected side effects include mild allergic reactions like swelling, itching, or redness around the injection site, as well as changes to the skin at the injection sites. Lipodystrophy is an abnormal fat distribution that resembles a small lump or nodule from repeated injections in the same spot. The most important adverse reaction is hypoglycemia. Hypoglycemia may develop due to an insulin overdose, increased work or exercise, skipping a meal, or illness associated with vomiting or diarrhea. A patient's insulin needs may be increased by other drugs that are considered to be insulin antagonists. This would include oral contraceptives, corticosteroids, epinephrine, and thiazide diuretics. Beta blockers can mask the signs and symptoms of hypoglycemia. Test the patient's blood glucose level before every insulin injection. Carefully check the order for the time, type, and amount of insulin to be given. Ensure that you are giving the right insulin concentration, for example, U50, U100, or U500, and make sure that you're using the correct syringe designated for that insulin concentration. Check the insulin vial for color and clarity. Some insulins are clear. This includes rapid-acting, short-acting, insulin glargine or Lantus, and insulin detamir or Levemir. All of the other types of insulin will have a cloudy appearance. If drawing up two different types of insulin, be sure that the prescribed insulins are compatible for mixing. First, draw up the shorter-acting insulin, followed by the longer-acting insulin. Be sure to gently roll the insulin vial or device between your hands to warm and mix it. Make sure to document the injection site and the rotation of sites to prevent lipodystrophy. Make sure the patient has a meal ready to eat before giving the insulin. Teach your patient and family the following. Teach patients the signs and symptoms of hypoglycemia and hyperglycemia, as well as the appropriate actions to take for each. Tell patients to seek emergency treatment for any symptoms of ketoacidosis. Teach patients the correct procedure for testing blood glucose levels at home. Teach patients the correct procedure to store, draw up, and inject insulin, rotate injection sites, or the care and use of an insulin pump. Always use a return demonstration to ensure the effectiveness of the teaching plan. An insulin vial in use can be stored in the refrigerator for 1 month at room temperature. Insulin should be warmed to room temperature for use because the injection of cold insulin could irritate the tissues. Check the expiration date of your insulin vial to ensure that your insulin is not out of date. Gently roll the insulin vial before drawing up the insulin. Any vigorous shaking could result in air bubbles and also breaks down protein molecules in the insulin. Avoid drinking alcohol because it can intensify the hypoglycemia produced by insulin. Insulin requirements will increase whenever under stress or ill with an infection. And always carry a readily available source of sugar in case symptoms of hypoglycemia develop suddenly.